Welcome back. Well, continuing our conversation about the planned strike of the National Association of Resident Doctors is today. Today is the day where they say they were going to down tools. They did put up a communique after their meeting. But we do have Professor Ken Ozoilo joining us this morning. He is a national president, Medical and Dental Council of Nigeria. Good morning, and thank you for joining us today. Well, you must have seen the communique issued by NARD. Part of that communique, in fact, let me even read section 13, the point 13 of that communique, which says, the NEC unanimously demanded for the sack of the registrar of MDCAN, that's the Medical and Dental Council of Nigeria, for failure to demonstrate competence in the handling of the central placement of house officers. This will give room for smooth implementation of the central placement of house officers without further delays. So they're clearly not happy with the MDCAN. What's going on with this?
Well, good morning, and thank you for having me once more. I want to say that once again we found ourselves in the unenviable and unfortunate situation where there's a looming strike by the National Association of Resident Doctors. It's truly unfortunate because this is something that is wholly avoidable and, entirely preventable. Now, to understand that aspect of the demand of the residents, I think we need to look back at the origin of the idea that the Medical and Dental Council of Nigeria should take over the placement of house officers, all right? Because this will give us a perspective. At a point in time, it was very difficult for house officers having completed their training and having been licensed provisionally by the Medical and Dental Council of Nigeria to secure placement for housemanship. And at that point in time, it was thought that, okay, since the Medical and Dental Council does their licensure as doctors, they should be able to provide placements, and that if this were centrally coordinated, the myriad of problems from different hospitals will be eliminated. Okay, so this is the background to now find ourselves at this point where the Medical and Dental Council of Nigeria itself, it's introducing the obstacle that is making it impossible for this process to take off smoothly. I think is truly unfortunate. I'm more concerned about the council itself, and I think that the solution to this problem is to be found with the council, and I think the council needs to exhibit some degree of pragmatism, all right? They were brought in to solve a problem. They cannot constitute a problem themselves.
So, Prof, pardon me if I misunderstood you or misunderstand you. Are you indicting the council in the handling of this matter?
I think there's a lot of failure on the part of the council. I've interacted with many of the stakeholders and many of the dramatis personae. We have had interactions with chief medical directors across the country, and as well as residents across the country. We've had interactions with the house officers across the country. It is, we've also reached out to the Medical and Dental Council. And I think at this point, the solution lies squarely with the Medical and Dental Council.
Oh, okay. We'll go to break, but we'll come back and shed some more light on this matter so that we could help a lot of people understand what really is going on, and then eventually proper solutions to ensure that the sector runs smoothly. Nobody wants any further destruction, especially coming from where we are. COVID hits the economy. We're back in a moment. Stay with us. All right, right, welcome back to the program. So, Prof, this disagreement that your association is having with the Dental Council, the meetings, as there's been several meetings, I reckon. So, what kind of conversation came up from that meeting? Was there any agreement? Because it does appear as though there is still huge disagreement over who should be doing what between MDCAN and your association.
I want to just clarify a few points. You know, in the structure of the health manpower from the doctor's side, you know, at the lowest of the ladder, you have the house officers, you know, then the resident doctors, and then the consultants. You know, the issue at stake is between the Medical and Dental Council of Nigeria, as it were, and not really the medical and dental consultants. You know, we've been trying to mediate. You know, our association has been trying to play a conciliatory role. And in the process of doing that, we've been engaging with both the Nigerian Association of Resident Doctors, that's the group that is calling the strike, as well as the Medical and Dental Council of Nigeria. You know, and like I said, at the very beginning of this was the need to provide placement for house officers. You understand? Initially, this was done by each training institution, each hospital, like each teaching hospital. You know, each hospital would employ its own house officers and pay them. All right. Now, from my engagements, I understand that the Medical and Dental Council, which is responsible for licensing the doctors, is saying that some of the hospitals have exceeded the quotas allocated to them by the council. And because of that, they will not be able to honor the list of house officers emanating from those hospitals. Now, upon interaction with the chief medical directors, you know, they have listed the problems emanating from their own sides too. But the reality on ground is that right now we're not talking about placement. House officers who have been employed have been working for upwards of 3 months, and many of them, majority of them, have not been paid. So this is not an issue of looking for placement for them. This is an issue of paying people who have been working. And what moral justification we have to continue to insist that people who are working should not be paid. So this is the problem, and I'm saying that I expect the Medical and Dental Council to be more pragmatic in the sense that, you know, these are doctors that are already working. They have been placed. They have already, begun to work, and they've been earning their salaries up to now. So the process of moving the placement from the hospital to the council should not constitute a further problem. Yeah. Okay, I think that they would need to revise their position. Okay, it might be necessary to give a period of a moratorium. Okay, such that the people that are currently doing house job will receive their emoluments seamlessly to the end of their housemanship, which is just a period of 12 months anyway, while the process of recruiting new ones and placing them across the country is further fine-tuned, as it were. So yes, I think that the council has a lot to do. By council, I mean Medical and Dental Council of Nigeria.
Well, this doesn't paint a very good picture, because, I mean, you are the Medical and Dental Consultants Association of Nigeria, and then the Medical and Dental Council of Nigeria are supposed to be the supervisory body to ensure that they whip everybody in line, to ensure the standards, the ethics of the profession is upheld to the highest of the standards. So if those who they're supposed to be, quote unquote, supervising are up in arms against them, doesn't that then send very worrying signals in the industry that this might just have a lot more damage than we can even see right now?
I think it does, absolutely. I think it does, but I think there's a need to put things in perspective, okay? Because relating with the regulators, that's the Medical and Dental Council, my understanding of their position has been that there's this tendency for the training institutions, that's the hospitals now, to employ more house officers than they are accredited to engage. Okay, and if that be the case, Council does not want to recognize the excess numbers over and above what has been approved for employment. Okay, but relating also with the chief medical directors, this is the point I'm making. Relating with the chief medical directors, they have very, very genuine reasons why they are, forced, as it were, into the corner they are. For instance, I'll give you an example. A training institution like the University of Jos, where I am, has a quota to produce about 150 medical graduates per year. Now, if the sister training hospital, that's the teaching hospital, is not able to absorb more than half of that, where do you send the remaining? And so this is why we're saying that the problems are real. And then if in order for the teaching hospitals to expand their capacity, their accreditation status, there are some concrete problems they may not be able to overcome in the short run. Okay? And so the problems are genuine on both sides. But I think the important thing is for both parties to realize that this arrangement came about as a result of the need to solve a problem. And that problem was the fact that there were thousands, hundreds and thousands of junior doctors, house officers who were roaming the streets without any place to do their housemanship. And so the pragmatic thing to do now is to make it possible for them to do that. And then it is even more important than those who are already employed have to be paid their emoluments. It's as simple as that. So I think that the MD, Medical and Dental Council, needs to soft pedal and allow the people that are currently working to, exit before any new enforcements are made. It's very important. This is what needs to be done, and not everybody digging into their positions and forgetting that this was a solution, as it were, that everybody agreed to a long time ago.
Ultimately, Prof, it's about the people. And perhaps we seem to be losing sight of that, just as you said, when everyone seems to be holding on to their horses and no one seems to be willing to bat an eyelid. Now, a strike has been declared, and according to what we have in the news and all, the likelihood is that the strike should begin today. Now, in the light of that, what do you see happening? Clearly, it would seem like the MDCAN isn't working as much as they want to, according to their website, with the NMA, which is, part of your own, parent body, so to speak. So what do you expect to happen now, especially from the angle of the MDCAN? Because clearly, the position of the NARD is known. What should the MDCAN do now? Because ultimately, as we said, this is about the people.
Thank you very much. Like I said at the outset, I think it's very unfortunate that the situation has been allowed to degenerate to this level. The strike is almost certain. The strike is also most avoidable and most preventable. At the end of the day, a solution is going to be found. There's going to be negotiations and discussions, and, a compromise will be arrived at. It's unfortunate that we're not able to, work towards that compromise without the damage that will be inflicted by the strike, if it goes ahead. And this is one of the problems that we have, we as doctors and as groups in this country, because the government and its agencies, tend to box you into a position where you seem unable to achieve anything without a crisis. This is most unfortunate. Okay, and this is a recurrent decimal. The ASU issue was just sorted out, after a very long and protracted, and if you ask me, unnecessary strike. Okay, last year it was the same with NARD. this year, here we are again, you know. So there's this impression that if there's no crisis, the government will not listen to you. And it's most unfortunate because at the end of the day, prices are paid, and these prices are paid in terms of human lives, okay? And this is most unacceptable. And therefore, government needs to do more. I keep emphasizing government and its agencies, okay? Yes, the strike is going to go on. The damage is going to be done. It is unfortunate because there's a limit to the amount of skeletal services that the consultants will be able to provide. The bulk of the workforce of the teaching hospitals across the country is constituted by the National Association of Resident Doctors, okay? And so everything ought to have been done, ideally, to prevent this kind of situation arising, okay? I want to restate my position, you know, that at the end of the day, there's going to be dialogue. At the end of the day, there's going to be dialogue, and there's going to be compromise, and there's going to be shifting on ground. And I think at this point in time, the council, the Medical and Dental Council, you know, has the solution to this problem entirely. If you look at the demands of the resident doctors, everything is genuine. Everything is genuine. You know, it's not just about the house officers. The house officers issue is just one issue. You know, a lot of it has to do with the promises made by government during the first wave of this COVID-19.
Well, Prof,
look at the hazard allowance of the doctors, even the house officers.
Right.
Look at today we're talking about brain drain. These people are leaving because the country is not able to treat them better. And yet, those that are still behind, you know, you leave them in a situation where they are forced to take these kind of actions in order to be heard. It is most unfortunate.
Well, Prof, speaking of their demands, I'm looking at that communique that was put out. One of the demands is the NEC unanimously demanded for the sack of the registrar of MDCAN for failure to demonstrate competence in the handling of the central placement of house officers. Do you think that will work? Is that taking it too far, or is perhaps just right?
I must state that I have not been able to discuss with the registrar one-on-one. I've tried to reach out to him. I've not been able to get across to him. But I've been able to reach other members of the Medical and Dental Council of Nigeria. And I think the problem, I wouldn't want a situation where it is personalized to the registrar, because if he's sacked and council maintains his position, then we've not achieved anything. And that's why I choose my words carefully. The problem and the solution are to be found in the council. Thank you.
This looks like it's going to be a long day, weeks, months, hopefully not, for consultants and other senior doctors. So for you, right where you are, has that strike begun? What is the plan? Because I imagine that the patient volume will not drop. I mean, they're not going on strike. Sickness does not go on strike. So what is the plan really? And how long a day or weeks will this be for you?
Well, it's indeed going to be a long day, you know. From information reaching us, it has kicked off. Prior to this, we've already switched into the crisis mode. We've been holding meetings, you know, with the management of the different hospitals to try to develop mitigation measures and stopgap measures. And part of that is for the hospital to change, you know, its mode of operation. It will not be possible to provide the full complement of services that we're used to. Obviously, all non-critical patients will have to be, you know, let go and asked to seek alternative places of help. Yes, we will continue to attend to emergencies and critical patients who cannot be discharged. But like I was saying, the onus of this now falls squarely. The burden of this falls squarely on the consultants. Those are members of my association, you know, who by their hierarchy in the organogram have to stay back and provide these skeletal services. You know, we do hope that it is a brief strike. We do hope that government sits up, the relevant agencies and all the people involved. We do hope they sit up and give this crisis the urgent attention that it deserves. And we do hope that it will be quickly resolved. But we will be reviewing our own modus operandi as the days go by. If the strike becomes protracted, then obviously it's going to take a heavier toll because, like I said, the bulk of the workforce of the, training institutions falls squarely on the resident doctors. Okay, the consultants are far fewer in number and will not be in a position to take over completely the job schedule of the resident doctors. So we do hope for a quick resolution.
Well, clearly that means that the country will feel the pinch if and when they do embark on that strike. But the list in that communique, almost everything there is very important as they listed. But given benefits of hindsight from your wealth of experience, looking through that communique, when you say you do hope that it will not be long drawn, what kind of issues do you think that if they are addressed, there just might be light at the end of the tunnel in terms of them suspending or calling off the strike? Because, I mean, assuming they don't attend to all of them.
Yeah, like I said earlier on, going through the list, almost every demand there is genuine. Almost every demand there is germane, because this sales did not start today. However, if you look carefully at it, you will see that there are immediate and, remote causes. And the most immediate one has to do with the remuneration of this house officers. It's most embarrassing for those of us in the medical profession because the house officer is the lowest in the rung. These are people that have just emerged from their schooling. Some of them have not been paid. Some of them have no other means of support, and they're the most junior. They're the ones that do not have any savings. They do not have any reserves, as it were. So to have the most vulnerable, the most feeble in the rung, being visited with this degree of hardship is embarrassing for everybody and it's most heart-wrenching. Okay, so I think that's one of the most immediate causes. As soon as that is resolved, we might be a bit closer. Of course, again, government made several promises during the heydays of, during the early days of COVID-19, especially to do with the hazard allowance. Okay, for goodness sake, the hazard allowance of these doctors, some of whom have died after contracting COVID, is 5,000 naira per month. Government made a commitment on its own, voluntarily, without prompting, and said, okay, look, we're going to increase this hazard allowance. We're going to pay you so much for the first 3 months. In another 3 months, we'll extend it. And after that, there will be a holistic review of not just the hazard allowance, but the emoluments. Because look, let's face it, what's driving people out of this country, bottom line, is pay. You understand? And government makes this commitment on its own and then goes to sleep shortly afterwards. Okay? So I think that some of those things will have to be addressed. Of course, some of them, like the death in service, the benefits of the death in service, with the new pension reforms and all that, it shouldn't be a big problem to, get the right people to do the right thing, okay? And then, get the whole issues resolved. Of course, other issues can, still be subject to discussions and all that. I'm aware that even the Medical Residency Training Act, which is another bone of contention here, is something that has been passed by the National Assembly, accented by the president, and nearly 2 years on, we're still quarreling with its implementation. You understand? So a lot of these things it's not rocket science. It's not rocket science. And these are commitments already made by government that should be honored.
Prof, I've looked through some other bodies, even sports bodies globally, and there seems to be some change. They're changing the leadership, the management of those bodies, bringing in other ideas to ensure things run smoothly. And I do remember, I think 2018 or thereabout, the NMA was up in arms against governments, giving them ultimatum here and there, asking them to reconstitute the board of the MDCAN. And now MDCAN is in the thick of this challenge. Do you think we should leave the leadership and management of the healthcare sector to professionals in that field alone, or should we change something? Because if today is Juhesu, tomorrow who knows what. How should we approach this?
Okay, touch something that is very important and topical. There has been that argument, and I think without reservation, yes, there's a need for change, you know, in different sectors, and different sectors have witnessed it. But one thing I want you to look at, and this is my personal analysis of the situation, there's a huge difference between the operations of public health services compared to private health services. The public sector, and this is not restricted to health, the public sector brings along with itself a lot of baggages. There's a lot of inefficiency, there's a lot of waste, there's a lot of, you know, I don't know how else to put it, that you don't find in the private sector. And so what I would like to see is greater private sector engagement. I do not think that it will matter significantly who is at the helm of affairs, insofar as they have to continue working with the same systems. But you will agree with me, you know, coming from your private sector background too, that the private sector has a more business-like approach to issues compared to the public sector. So I think that this is the discussion we should be having. You know, I've challenged a number of government officials when we talk about issues to do with salary. You know, if you engage any government officials, those involved in this thing, once you call a degree, they reel off the salary. Once you mention a grade level, they reel it off, you know. And what this does is that it does not encourage that individual extra effort. Okay, because it's not remunerated. But in the private sector, your value to the organization is directly proportional to the amount of, you know, results that you're able to produce. We don't have that in the public sector. And if you ask me, I think that, you know, what we should be looking at is how government can greater reduce its participation in the business of health and other businesses by encouraging and enhancing greater private sector participation, so that you can bring in a lot of the private sector efficiencies, you know, and competencies, okay? And even funds, because anytime you see with governments, it's always issue of funds, but it does not really have to be that way. If you incentivize private sector participation, they'll bring in their own funds and yet produce better results, you know, per amount of capital involved. So as far as I'm concerned, this is the direction we should be looking at.
Well, Prof, if you'll allow me to use a word that you used earlier, it is unfortunate that that's the kind of thing that we can say about the public sector, being that they're human beings, just like the people in the private sector. But there was something you said the other time about the patients having to seek alternative medical service. That's a little curious to me. I'm using your words verbatim because the same MDCAN regulates the activities of alternative medicine. So I'm wondering how that is going to play out.
Okay, I'll plead with you. Okay, I'll plead with you. What I meant was alternative places. Okay, I do not want to dabble into the issue of alternative medicine. Okay, so let's get that right. And by that, what I meant is, you know, because the strike is only going to affect public hospitals, as you well know. So the private hospitals will still be open and available, but we know the challenge there is largely to do with money. Okay, because most of them are more expensive than the government places, you know. But right now, that is the only backdrop that we have to take the slack from this crisis.
Now, it's interesting. You cited this earlier, so let me just play on it a little. From time to time, we have had cases where the NERD has had to you know, call its members out on strike because of one thing from the government, or the one thing, you know, from the Federal Ministry of Health, and here and there and everywhere. And as you said, agreements that are broken and all. So on the one hand, sometimes it's the federal government, the Federal Ministry of Health. Now it's the MDCN, and sometimes it's even MDCAN. I'm wondering, just a question here in my head. Do you think that sometimes the NERD is a little overboard?
I want to first of all quickly dissociate my association from the genesis of any crisis. I want to say that largely over time, the medical and dental consultants have been, you know, equally affected as adversely, you know, by most of the issues raised by the NARD. If you read the fine lines in those in the communique, you will see that a lot of the what we now call the COVID-19 era promises of the federal government is not only for resident doctors; it's for everybody, and it's not even only for doctors. You know, it was a promise made to the health sector. Okay, so I want to quickly, you know, put that right. You know, most of the things that affect residents also affect consultants. Okay, but because of the organogram, as I've been saying, because of the structure of the workforce, the consultant takes ultimate responsibility for the care of the patient.
All right, Prof.
Hard pressed to find themselves in a position where they will have to, you know, leave the patients unattended or down to. So what we do is to provide that safety net, especially for emergencies, okay, to be able, so that the patient is not entirely left without any hope.
All right, then, Professor Ken Ozolu, President of MDCAN, thank you for talking to us this morning.
Thank you very much for having me.